About the scholarship, yes, it's okay. The certificates will be here.
We will give the words after the first speech, because we will have the certificate in 10 minutes. Okay? Please, Jean-Marc.
Okay, so I have the pleasure to co-chair this session with Professor Di Lorenzo. So this is the session of the European chapter, Evidence-Based Medicine. So we selected the top European bariatric and metabolic surgery science paper. And the first one will be presented by Ralph Peterli, 10 years results of the SM-BOSS trial. Ralph, yo.
Dear President, I don't know how you say that, if you're ingoing and outgoing president at the same time at the podium. Thank you for the introduction. I'm going to give you our long-term results. They have not been published yet, so this is, hasn't gone through a peer review. These are my disclosures, and you can see that our primary procedure usually is bypass, and it's getting less and less sleeves. Maybe you understand at the end of the talk why. This trial had an objective to control whether the sleeve at the time as an isolated operation was rather new, is as effective and safe as bypass at 5 years. And these are 4 centers that participated in Switzerland. The primary endpoint was excess BMI loss at 5 years, and we had a number of secondary endpoints, and we also had some mechanistic studies done within the trial. So it took us quite some time to recruit the patients. You can see here we screened quite a large number of patients. And at that time, the Swiss patients already had kind of an opinion which kind of operation they wanted to have. So it was difficult to randomize such 2 operation types that are so different in anatomical changes. So at the end, we had more than 100 patients in each arm, and at 5 years, we had a follow-up rate at 95%. We did publish the 1-year results, and we could show that the sleeve was faster, a little bit safer, but not statistically significant. The weight loss was same. 3 years, the weight loss was still the same. Complications, quality of life, and comorbidity were equally improved, except GERD and dyslipidemia. Bypass was better, and we had the same rate of vitamin deficiency. So anybody who thinks with a sleeve you don't have to take in any supplements is wrong. We had the same rate of deficiencies, but maybe the severity of the deficiency was different. And we had these spaghetti plots of the weight loss, and it turned out to be that the excess BMI loss in average was 68% for the bypass and 61% for the sleeve. And after adjustment for multiple comparison, this difference was not significant anymore. And yet, if we compared a secondary endpoint, percent weight loss, and compared from 0 to 5 years, this difference was statistically significant. So there was a trend to a bit more weight loss in the bypass group compared to the sleeve. So 10-year results, we again looked at excess BMI loss as primary endpoint, and we had also looked at the total weight loss, comorbidities, complications in terms of complication, comprehensive complication index, which not only counts Clavia-Dindo complications, the highest one, but takes into account if you have multiple complications, so it reflects the burden of complications to the patient. And we also applied the SF-Bari score that we designed together with Paulina and Marco Büter at this time point. So initially we were 4 centers with 217 patients that I already shown to you. And 1 center did not want to deliver the 10-year data, so actually for this analysis now we have 188 patients to start with from 3 different centers. These are the baseline characteristics. They were still the same in terms of gender distribution, age, weight, and comorbidities. And this is the ITT population, and 76% of the patients had a 10-year follow-up. Weight loss in the intention to treat population was not statistically significant different from Roux-en-Y to sleeve gastrectomy in terms of excess BMI loss or total weight loss. But if you looked at the patients who still had their original operation, we had 34.4% of the patients had to be converted from a sleeve gastrectomy to another operation, other anatomy, and only 6.3% of the bypass patients had to be converted into a long BP limb type of Roux-en-Y gastric bypass. The reasons were GERD, weight loss issues, or both, and also strictures, which may reflect a certain learning curve of that time. And in the bypass group, it was always due to weight loss issues. Shorter than suboptimal clinical results or recurrent weight gain. Anyway, so in the PP population there, we had a significant difference. So all the patients who still had the sleeve had an excess BMI loss of 55% and the bypass 65%. So this gets to a point where you can say this is probably biologically important. And if you look at the series RCTs, if you look at the sleeve pass trial at 10 years, it's only because they made a equivalence trial with pre-specified margins that they didn't reach the margin, but if you didn't have that as a trial design, it would also be more powerful in terms of weight loss at 10 years for the sleeve pass trial, and definitely in the per protocol analysis, bypass is more efficient in terms of weight loss. Complications, more gastric esophageal reflux, more intraluminal hernia in the bypass group, and I don't know why the slide is here now, but actually if you look at the comorbidities, and the numbers are the prevalence of this cohort at baseline, there was no difference in terms of diabetes remission, but we were definitely underpowered for that endpoint in that trial. Dyslipidemia was more remission and less de novo, less worsened. So in total, it was better treated with a bypass compared to a sleeve. Hypertension, there was no difference. And obstructive sleep apnea syndrome was no difference between the two groups at 10 years. GERD, there are remissions of GERD symptoms, but we had new onset GERD. At 5 years, it was 31%. At 10 years now, it's almost, that's 28%, and none in the bypass group. And we published that separately. The de novo Barrett at 7 years was 3.6% in the sleeve group compared to the 1.2 in the bypass group. That is very similar to the results of the sleeve pass trial at 10 years. So we did apply this new composite endpoint because we figured we need a composite endpoint to compare head-to-head certain trials or certain treatment modalities, also conservative ones. So we designed that weight loss is the main driver for most of the improvements of bariatric surgery. We looked at the comorbidities that most series do report. And again, we put in the complications and the side effects with the CCI. So on that, we did not see a significant difference between the two operations. So sleeve was good in terms of this categorization of this score of good results in both treatment arms. So in summary, if we compare these two operations, I mean, we're very happy that we have these two options. And I mean, I know we have more options, but if you compare these two operations that have been performed the most often in the world, in the PP population, per protocol population, the excess BMI loss was 10% higher in the bypass group. Comorbidities were treated a bit more efficiently if you take literature into account after bypass, dyslipidemia, GERD, and the safety issue early, possibly the sleeve is a bit safer, it's a bit easier. 5 years, they're about the same, and at 10 years, it is not significantly different except for the conversion rate. 1/3 of the patients needs another operation for weight issues or GERD. And another advantage of the bypass, it's reversibility, which we don't have in the sleeve. So in conclusion, we define good candidates for sleeve with patients with a very, very high BMI, necessity of endoscopic access of the remnant or of the stomach, or after extensive previous surgery, expected adhesions of big abdominal wall hernias, and a relative indication, in our opinion, is Crohn's disease, professional driver who are afraid of dumping symptoms, or elderly patients which sometimes need more time after a bypass to recover than a sleeve patient. And then a very good candidate for bypass is GERD, large hiatal hernia, esophageal motility disorder, type 2 diabetes, dyslipidemia, or the patient can wish after he has had all the information necessary to make a good choice. So thank you very much. That was it. And I announced these two Congress or practical courses. Thank you very much.
Thank you, Ralph. Well, the paper is open for discussion. You have any, please?
The microphone is probably not working.
Yeah, doesn't work.
No, can you try to switch it on?
Go ahead, go try again.
Hi, okay.
That's
Okay.
Baba Savas from the US. Thank you for presenting such a great study. I saw no ulcers in your gastric bypass group at 10 years. Can you make a comment about it?
You're right. That was a time when we made small pouches. And today we have an ulcer rate in these small pouches of 1%. And if we make longer pouches to decrease the dumping issues, we have much higher rates of ulcers. But it's true, in that group, we did not have ulcers to take care of. Or, I mean, just very few. Not that they had to be reoperated, or that they were severe enough that they were hospitalized. So maybe there is maybe we did not detect all of them, but actually we did detect. I mean, there are 76% of the patients are still in the control, and I think we should have, if there were, we would have detected them.
Okay.
Torsten?
Thank you, Ralph. I'm putting the same question as I did in Zurich, that you've been through a randomized trial, you've been with the professionals, the surgeons, and this community, the patients. What is the split right now with your practice, how patients choose after your information? What are the percentage of sleeves and what are the percentages of bypasses?
10% sleeves, 90% bypass.
Okay. 80-20.
And we started out with 40% sleeves and 60% bypass.
So, congratulations again. I love the data. It makes me rethink everything I thought I knew, think over again. What about alcohol use disorder? Something that is up to 20% of our patients. Maybe there's a difference between the two. Did you look at this as well?
Actually, it would have been noticed. And I mean, we're very strict with the selection of patients. And obviously, we do have them, but not in this cohort. I mean, it's a highly selected population. But we do have it, but not in the numbers that you have in some of the literature. It happens, but it's very rare.
Okay, thank you, Ralph.
So thank you very much. As you saw, we started with a very nice paper, the presentation of the chapter, the best papers, the best researches done by the Europeans. Now we stop for a moment the session because we have the awards of the IFSO EC scholarship to be given to 3 people who were awarded for this. And I will call to the podium Anne Jacobs, Radu Petru Saraceanu, and Amanda Belluzzi. So. Done? Amanda Belluzzi. Now, we go ahead with the second presentation by Paulina Salminan, the president-elect of the chapter. And the title is very long, Paulina. Can you say the sleeve pass randomized clinical trial?
Yes, you can.
Thank you.
Thank you, Nicola and Jean-Marc, and thank you very much. I'm happy to be here, part of this IFSO EC session, and I will present our 10-year data for the sleeve pass trial. So these are my disclosures, nothing relevant to the presentation. So I will have to start at our 5-year results because that was the primary endpoint. The trial is sleeve versus bypass. We enrolled the patients between 2008 and 2010, quite at the same time as the SM-BOSS trial. They just took a bit longer. We were able to finish our enrollment a bit earlier. We had 240 patients and 3 centers in Finland, and some of the co-authors are here in the audience also. This was designed as an equivalence trial. And this I need to state very clearly because for an equivalence trial design, you need to have the pre-specified equivalence margins. And our primary endpoint was % excess weight loss because at that time it was the parameter that was supposed to be used for the weight loss assessment. And of course, at that time, because we started in 2008, there really was no data to base the predefined equivalence margins on. So that is sometimes tricky with an RCT that you're stuck with the original study design at a later stage, but this just has to be acknowledged. This means that our 5-year primary endpoint data is the way that Roux-en-Y was actually associated with greater weight loss. Procedures were not equivalent, but there was no statistically significant difference based on these pre-specified margins. And like I said, this is study design. So no difference between the groups, but there was, the weight loss was a bit higher, so I will show you the results, 8.2 at that time. Now let's focus on the 10-year data, because this is the paper that came out last year for our 10-year follow-up. And this is also upfront confession on the fact that when we started enrolling the patients and initiated the trial, at that time, we really did not understand the prevalence of GERD related to sleep because we did have an exclusion criteria of severe GERD and a large hiatal hernia, but unfortunately, that was not a standardized assessment, nor did we have a GERD symptom assessment preoperatively. So that's the baseline problem. But we did do a gastrointestinal endoscopy to all of the patients preoperatively, so we know the status, but like I said, GERD was not really, only severe GERD and a large hiatal hernia. That was the protocol. So we had to do an amendment for the 10-year follow-up because, of course, now with the emerging data that sleeve would be associated with up to 17 or 14% Barrett's, we wanted to do an endoscopy at 10 years. So that was the 10-year data was actually more, of course, additionally focused on GERD compared to the original study design. This is the 10-year flow chart. Like I said, 240 patients initially. And at 10 years, we had the overall follow-up percentage of 85%. And 78% of the patients underwent gastroscopy at 10 years. So this was, we were quite happy with this, but we were really adamant about getting the patients in for the gastroscopy. You have to note that, as Ralph was presenting, conversion rate between the different groups, I don't know where you can convert a Roux-en-Y gastric bypass, so that's why I put in the reoperation rate between the groups. So for the procedures, it actually is the same. But again, I would say this has something to do with the original study design, as I'm sure there were patients in the sleeve group that we would now currently, with the current information, perhaps not randomized to a sleeve gastrectomy. And also for the bypass, because you look at the reoperation rate, the majority in that group is internal hernia. At the time, we did not close the mesenteric defect. So that is a similar issue for both groups. So that is really one of the limitations. But that's the 10-year follow-up rate. When you look at the weight loss at each of the time points, 1, 3, 5, 7, and 10 years, the weight loss trajectories are very similar. So bypass is a bit better at each time point, but there's no difference. Again, I'm going back to the equivalence trial design. So no difference between they were not equivalent, but the difference was not significant clinically based on the pre-specified equivalence margins. So here you see the percent X's weight loss for sleeve 43.5 and for bypass 50.7. And as you can see throughout the time, also at 10 years, the difference remains quite consistent. This is, again, the spaghetti plot, which the 5-year results, we were initially a bit puzzled to have this, but I think this is really informative because it shows the variability of the intervention outcome, because all the patients are separate lines, so you could be either where on that scale. When you look at the comorbidities, it is there was no difference in type 2 diabetes, and at baseline, we had 43% of the patients had type 2 diabetes, so it was much higher in our trial. And of course, with the merged data, what Ralph showed, we compared the two trials, so our patients were actually older, they had longer preoperative duration of type 2 diabetes, and the prevalence of type 2 diabetes was much higher. So at 10 years, there was no difference, but again, I would like to remind you that, of course, we're underpowered to detect this difference. This is a secondary outcome. And this was also similar for dyslipidemia and obstructive sleep apnea, but for hypertension, Roux-en-Y gastric bypass was superior. And this was also already evident at 5 years, so this remained at 10 years. So for hypertension, bypass was significantly better for the remission. And now going into the more detailed analysis of the GERD issue that we addressed at 10 years, and I realized that I'm missing the initial complication table from the presentation, but maybe I'm just going to state for the ulcers, we had 6.7% in the Roux-en-Y gastric bypass group, but of course no difference in the overall morbidity between the groups. But for the GERD symptoms, we did retrospectively assess patient PPI use preoperatively. But again, I would like to stress this is retrospective because this was not recorded at baseline. So the PPI intake at 10 years was significantly higher in the sleeve group, so 64% in the sleeve group and 36% in the bypass group. And when you look at GERD-related, health-related quality of life, the scores, the total score was significantly higher in the sleeve group, so it was affecting, the GERD was affecting their quality of life. For the more objective results on endoscopic assessment, I would like to stress when you look at some of the papers, really remember to look at how Barrett's is defined. Are they using the UK or the US definition? We did go with the ASGE definition. That's, I think, in the majority of Northern European countries, is that you need to have the intestinal metaplasia. Gastric metaplasia alone is not sufficient. So this is a key issue when you look at the papers. And we could go into the Seattle biopsy protocol because, of course, you also need to make sure where you take the biopsies that they are actually esophageal biopsies. And then you need to have the endoscopic finding associated with and together with the histopathology. At 10 years, the prevalence of esophagitis was significantly higher after sleeve. That's clear, 31% versus 7%. The majority were LA grade A or B, 92.9%, and but there was a very clear difference. And when you look at the prevalence of Barrett's esophagus, like I said, all of the patients underwent a preoperative gastroscopy, so this is de novo Barrett's. None of these had Barrett's before, 4% in each group. And all were short segment, non-dysplastic Barrett's with intestinal metaplasia. And just for the 10-year data, I'm not going to show you specifics for the quality of life. There was no difference between the groups, but I'm going to show you the 7-year paper of one of my PhDs from 2 years back. At 7 years, we did a specific analysis of the quality of life data, and it was significantly better at 7 years compared to baseline. Of course, again, no difference between the two groups, but greater weight loss was associated with superior quality of life. Thank you very much for your attention. This is our study group, not maybe the youngest member, that's for one of my PhD students. And thank you very much, and hope to see you in Vienna, in the IFSO EC, and then of course Melbourne. Thank you very much.
Thank you, Paulina. The paper is open for discussion. Question from the floor. I have a question for you, because these are numbers coming from a series, of course, which have been operated years ago. Which was your policy for hiatal defects in the sleeve patients at that time? I know that through the times in the last 15 years we changed our attitude in repairing the hiatus, but what was at that time?
At that time, it was very rarely the hiatal hernia was repaired. So I think that's also one of the issues that, like I said, we could have a whole symposium or a whole congress on hiatal hernia issues associated with this. But no, that's also one of the topics.
François Patou.
Yes, thank you very much. So for both of you, very important trial that everyone is expecting and is following for now 10 years and more. I have two questions for you. The first one regards GERD. So you say that at the end of the day, there is more GERD in sleeve than in bypass, with all the cautious remark you made in the beginning. But then you have 18% reoperated. In my experience, these patients have been all reoperated for GERD and severe GERD. So where are they? Are they in the 30% of GERD, or are they?
Yeah, they are. The reoperations majority are for GERD. Like I said, at that time, a lot of these patients that were converted for GERD, and of course then we go for reflux or suboptimal initial clinical response, or then recurrent weight gain. That also is not a clear black and white issue, because they're both associated with that. So, but the ones that were converted, the majority in the sleeve, that's for GERD.
Okay, so when my question is, where are they? Are they in the 33% or something like that you have at the end of the 10 years? Are they in there, or it's on top of these 30?
This is intention to treat.
That means
they're
that
in there.
They are on top.
No, intention to treat, so they're in there. They're in the sleeve group.
If they have been reoperated?
Yeah. It's intention, that's a randomized.
They have been with GERD. At 10 years, they
Yeah.
have been in GERD group. Okay, that's good.
No.
Thank you. So it's significant, but it's
No.
they are in it. Okay, second question regards weight loss. So I'm a little bit confused, because you say there is more. Is it
Oh,
more or
Francois,
not?
I'm so with you.
Is it
So
more
remind
or not?
me never to do an equivalence trial again.
Okay, so but can you say that at the end of the day, forget this methodological thing, that gastric bypass in the long term has better weight loss outcome than sleeve gastrectomy? Straightforward. Is it a yes or no?
Straightforward, yes.
Okay, thank you.
No, but that's actually the reason why we did the merged data of the two RCTs at 5 years, because that's how we knew it. It does have a better weight loss, but then when you look at the reoperation rate, that may be a bit higher, and the complete CCI was higher in the merged data for favoring sleeve, like Ralph said. But this is, again, black and white is easy. The gray area in between is very much more difficult. Go ahead.
Please.
Thank you very much for your presentation. One clarification, you said 18% sleeve reoperation and bypass
18. That's the same.
But you presented only 2 or 3, 4, 18% for bypass.
Yeah, that was the majority for internal hernia. The reoperation,
because
yes.
it was not listed.
Yeah, no.
So
Yeah,
18 in the
reoperation rate,
Roux-en-Y.
overall reoperation rate was similar between the groups. For sleeve, the majority were conversions for
That's very important.
from sleeve to, sorry if I was unclear on that, so from sleeve
I
to
thought it was a mistake.
No,
Okay.
and the majority were for internal hernia, but I would like to remind you, like I said, we did not repair the mesenteric defects at the time, so that is a high reoperation rate, which of course can be reduced because the majority were for that.
Thank you very much.
Thank you.
Torsten?
Thank you very much. Great to hear. I'm sorry I'm a little bit of a parrot here, but I think that when studying and seeing patients in parallel in this, it makes something with what we are doing. And I put exactly the same question to you. How has sleeve pass altered the procedure selection in Finland? What direction has it gone?
I think I think it has changed because I think now we were actually the most enthusiastic center to do sleeves, but it's gone down. So for me, I think it's now 40-60 for sleeve and Roux-en-Y gastric bypass. So it does have an effect because you don't want to do it in patients that are prone for reflux because at 10 years, you see the fact that that's what happens. And you know, even though I was commenting on the conversion rate, but of course that's the procedure. You will end up converting some of the sleeves. But then again, it may be a planned, or you need to have like up the treatment in some patients, and that's of course due to the chronic nature of severe obesity.
Last question.
Yeah, thank you so much. I have one question regarding the Barrett after bypass.
Yes.
So it's a bit surprising for me that it's the same after both surgeries. So do you have a recommendation if we should screen post-bariatric or post-bypass patients also for Barrett esophagus?
That's an interesting question because, again, we know that overall screening in the general population, like with Barrett's, that's really, if you follow up, that's really, their number needed to treat for endoscopy is really high to detect a carcinoma there. But I think you would, again, for the follow-up, maybe not every single one, but you would have to take into account like risk factors for these. But I don't think it's actually very strange because severe obesity itself is a refluxogenic condition. So bypass also for that, and you may, like I said, it's maybe also associated with the weight loss.
So maybe it's not de novo at all in the bypass cohort. So maybe
Well,
it was overseen in the first place 10 years ago.
We did the initial on the other ones. Of course, it was not overseen. I have to say that, but I'm hoping it's not because we did the endoscopies pre and post-op.
Last question.
Last
please.
question.
Thank you for a great study. If you were to disregard the intention to treat and included the conversions of the sleeve in the other, would there be a significant difference in weight loss?
If we did do a per protocol analysis, that's what you're asking. We actually did that. No difference.
No difference.
No. Thank you very much.
Thank you, Paulina. Thank you so much, and congratulations.
So now we ask Dr. Hofse from Norway to speak of the Hoseberg study, gastric bypass versus sleeve gastrectomy in patients with type 2 diabetes. Randomized controlled trial, please.
Okay, thank you. First, I'd like to thank the organizers for inviting me and for letting me present the results of the...
May I suggest you to speak closer to the microphone because the sound is not good.
Okay. Okay, thanks for the invitation. I'll present the short and midterm results of the Hoseberg study. And I'm not a surgeon, I'm an endocrinologist and I head the section of endocrinology and obesity and nutrition in Tønsberg in Norway. I'm also the principal investigator of this study. And I have no conflicts of interests. And this talk is going to have a lot of information, present data from 6 studies. The first study is the primary endpoint, the remission of diabetes. Second study focus on mechanistics and GLP hormones and beta cell function, assessed using an oral glucose tolerance test. Third paper, bone mineral density and turnover. Fourth paper on reflux. Fifth paper, liver steatosis, and the 6th paper, the last paper, I will present the 3-year results. Focus on patient-reported outcomes, weight, and diabetes remission. Okay, so if you're ready. First, OSBERG is an acronym. It stands for Obesity Surgery in Tønsberg, and it's also the name of a famous Viking ship from around 800 and was discovered at the OSBERG farm very close to our hospital. And you can see a copy. Okay. Here, with some members of the research team. And this is the hospital with a nice view of the coast. Okay, the OSBERG study is a randomized, controlled, blinded for the first year, single center study. 109 patients were randomized in a 1-to-1 order to either sleeve gastrectomy or gastric bypass. Subjects were had morbid obesity and type 2 diabetes. We also performed their upper endoscopy, and patients with esophagitis grade C or D were excluded. The same was for parents with Barrett's and a large hiatal hernia. The study was initiated in 2013 and completed in 2022, a 5-year. So these are the procedures. We used 25 French bougie. The step-in line started approximately 4 to 5 centimeters from the pylorus. And the gastric bypass was a standard gastric bypass with a 25 milliliter gastric pouch, 120 centimeter alimentary limb, and a pilopancreatic limb of 60 centimeters. Okay, the objective of the study was to assess the effect of gastric bypass and sleeve gastrectomy on glycemic control and insulin secretion and action. The study actually had 2 co-primary endpoints. One clinical, remission of diabetes, defined as having A1C below 6 without the use of drugs, and a physiologic endpoint, beta cell function, using intravenous glucose tolerance test. As you can see, we also had several predefined secondary outcomes listed here, and one of them is body weight, of course, and the other one is also another measure of beta cell function, and that was assessed using an oral glucose tolerance test. That was for the inclusion of the incretin effect. We measured bone mineral density using a DEXA scan. Several patient-reported outcomes were recorded using different questionnaires. Reflux disease was classified using the upper endoscopy and also a 24-hour esophageal pH monitoring system. Hepatic steatosis was assessed using an MRI. And the surgeons used similar skin incisions for both procedures, making the blinding of the study possible. So from 2012 to 2017, 319 patients on the waiting list for bariatric surgery were assessed for eligibility. 109 were not eligible. 93 declined participations, and 14 patients were excluded after further examination, and that was mostly due to GERD. So 109 were randomized, and we lost 1 patient in each group the first year. And at 3 years, the follow-up was still quite high, with approximately 85% meeting at the follow-up at the 3-year. These are the baseline characteristics. The majority were women. They were just below 50 years of age. The great majority were white, had white ethnicity, BMI 42, hemoglobin A1C just below 8%, diabetes medication, 90% were on diabetes medication, and 20% of them were on insulin treatment. The duration of diabetes was approximately 5 years. Okay. First year weight loss, 29% after gastric bypass and 23% after sleeve gastrectomy. As you can see, this is the change in hemoglobin A1C, and that was similar, approximately 2% during the 1-year follow-up. And I have to say that it was an intention to treat the target. So we were aiming for hemoglobin A1C below 7%. And this figure shows the use of diabetes drugs, 90% at baseline at 1 year. The larger portion of the patients in the bypass group had stopped using glucose-lowering drugs. And combining hemoglobin A1C with the use of medication, and you have the remission rate, and that was the primary outcome. And here we can, you have the results at 1 year, 75% remission rate of diabetes in the bypass group and 48% in the sleeve gastrectomy group, and that was significant. After publishing the 1 year results, we also did a meta-analysis, and the Osberg study and the Stampede trial were the two only studies only including patients with type 2 diabetes. But as you also in the previous presentation, the SMBOS and SleepPass also have a relatively large proportion of patients with diabetes, and these subgroups were also included in this analysis. And combining all the results, you see that the patients operated with gastric bypass have a 33% increased likelihood of diabetes remission. You can see that the Osberg study and the Stampede trial actually had very similar likelihoods ratio, risk ratios, so about around 1.6. Okay, this is for those of you who are interested in insulin secretion and action. As I said, we performed the intravenous glucose tolerance test and measured insulin sensitivity. And it was a great improvement in insulin sensitivity in both groups, and maybe surprisingly, taking into account the differences in weight loss, it was similar in both groups. Acute insulin response to a glucose injection was similar. Combining insulin secretion and action by multiplying them gives the disposition index, which is a measure of beta cell function, not including the incretin effect. And that was also similar, a great improvement in beta cell function. However, injecting glucose is not a very physiological way of testing the beta cell function. So we also did an oral glucose tolerance test and measured the gut hormones. Here shown, you can see GLP-1 with a massive increase and a much greater increase in GLP-1 after an oral glucose load in the bypass group. And we also measured glucose and C-peptide and calculated beta cell sensitivity. Here as a measure of beta cell function, written twice, I see. And that was significantly higher at 1 year in the bypass group. We also performed a mediating analysis, and that actually showed that the type of surgery had an independent effect through GLP-1 and beta cell function on the remission of the diabetes. This indicates that gastric bypass surgery has a weight loss independent effect on the remission of diabetes. Okay, I'll continue with the bone results. We used, as I said, a DEXA scan to calculate bone mineral density, and there was a greater reduction in bone mineral density in the femoral neck, in the hip, and also in the lumbar spine. And the reduction was greater after gastric bypass in all three regions. And the same was true when it comes to bone turnover, greater bone turnover after gastric bypass surgery, and that fits into the history of a higher likelihood of osteoporotic fractures after gastric bypass surgery compared to sleeve gastrectomy. Okay, this is the liver fat, hepatic steatosis, and we measured liver fat fraction using the MRI. And you can see a very drastic and rapid reduction in the liver fat within 5 weeks, and also a further slight reduction after 1 year, and that the reduction was similar in both groups. Okay, I'll also have some data on the reflux disease, as discussed previously in the 2 first sessions. The prevalence of GERD symptoms, esophagitis and acid reflux was relatively high at baseline. And it's worth mentioning that the patients with objective findings of GERD, that's esophagitis and acid reflux, most of them were asymptomatic. There was a reduction in both symptoms, esophagitis and reflux, and especially a greater reduction in the bypass group, and the prevalence was lower at 1 year in the bypass group compared to the sleeve gastrectomy group. Okay, the last papers, slides, I will show the results from the three years results. First, body weight, weight loss from Nadir. At 1 year, you can see there is a slight increase in body weight in both groups, but still a large difference at 3 years. Comparing that to the Stampede trial, you see a slightly lower reduction in body weight compared to the Stampede trial, and that may be due to slightly different techniques. The Stampede trial used 30 French bougie, we used 35, and then we also have greater preservation of the antrum. Remission data at 3 years. After 1 year, a few patients had relapse of diabetes, but still a much greater remission rate of diabetes at 3 years compared to the after bypass than compared to sleeve gastrectomy. Okay. The results from the impact of weight of quality of life light questionnaire shows that gastric bypass was associated with a greater improvement in physical function, better self-esteem, and a reduced public distress. And these are the 3 years result from the gastrointestinal symptom rating scale, and not unexpected, greater or less greater reduction in the reflux symptoms after bypass surgery, while the others symptoms did not differ between the two surgical groups. Okay, the final topic, complications. We used the contracted accordion classification system, and up to 6 weeks we had 18 complications. 14 were mild, 2 were moderate, 2 were severe, and there were no deaths. Late complications, all kinds of complications, were recorded during the visits at our center. A total of 57 late complications after gastric bypass, after sleeve gastrectomy, and 52 after gastric bypass. The most common complications were infections, gastrointestinal complication, and cardiovascular complications, and they did not differ between the two surgical groups. One sleeve gastrectomy patient was converted to gastric bypass because of insufficient weight loss, and one patient was gastric bypass patient was reoperated because of small bowel obstruction, and 4 patients underwent cholecystectomy. And there were no deaths at 3 years. So, in conclusion, short and mid-term results from the Oseberg study, including patients with type 2 diabetes and obesity, show that gastric bypass is superior to sleeve gastrectomy regarding weight loss, remission of type 2 diabetes, weight-related quality of life and reflux symptoms, and loss in bone mass is greater after gastric bypass than after sleeve gastrectomy. We believe that these differences should be reflected in the international diabetes and obesity guidelines. They are not. The diabetes guidelines do not discriminate between these two procedures when they recommend surgery for diabetes, and we believe that there is not enough evidence to make a change there. So I'd like to thank all the participants. I'd like to thank my collaborators in Copenhagen, in Oslo, the research group in our hospital, and I'd especially like to thank Göran Hjelmeset, Rune Sandbu, and Marius Svanvik, who is here today. Thanks for your attention. I would also like to say that if you're interested in the
Thank you
5
very
years,
much.
I just
So
want to
we-
say that if you're interested in the 5-year results, you can hear them at the diabetes meeting in Hamburg.
We were told that the efficiency of the bypass was independent of weight loss and due to duodenal exclusion. And in the sleeve gastrectomy, there is no duodenal exclusion and no difference at 1 year, and the difference occurs after 3 years. How can you explain that?
Sorry, I think no difference at 1 year.
No difference in the remission of diabetes.
It was a great difference in diabetes remission also at 1 year.
Yeah.
For 75 versus 48% at 1 year, and 2/3 at.
No, but my question is, what about the so-called duodenal exclusion?
Yeah, I think
which was supposed to be the difference.
But as I said, there is a big difference in the remission rates at all time points, and I think that I'm sorry if I don't understand the question.
Okay.
Okay.
Anyway, so please.
Hello, Maud Robert from France. Congratulations for such a great work.
Thank you.
Did you have difficulties with blinding? Because I understood that the patients were blind for the procedure. So did you have ethical difficulties to validate the protocol? What did you had some patients who were readmitted in emergency because of a complication, and you have difficulties to diagnose that, or well, it's quite difficult to blind the patient.
And we had some ethical discussions about that, and that the reason why we stopped at 1 year was because we wanted the patient to know. And we had a list of all the patients in the RE, emergency room, so that if a patient in the study, and it was also noted in the journals, that if the patient was admitted due to abdominal symptoms, it's easy to find out which operation, and also a CT scan would have given the answer if they're gone to another hospital. And we told the patients about it. So, but we had a discussion about it. Yeah.
Thank you.
François Patou from France. So I have one small comment and a question. So first, congratulations. It's a very important piece of work, and several works, of course. My comment regards something which is overlooked very often by our community, is loss of mass of bone.
Yeah.
And you just briefly said that, but there is now several evidence that gastric bypass does bad for the bone. That's important to know, because you say at the end that gastric bypass is better. We think for many reasons it is, but that's a small thing we have to remind. That was my comment. My question is because in France now metabolic surgery, BMI 30 to 35, has been approved and reimbursed. This is now prime time since few months. But we were unable, the group, to find any evidence in this specific group of patients of superiority, whatever we think, whatever we have intuition of, and you showed that gastric bypass might be better in terms of remission of diabetes. That was the primary outcome looked by this assessment. Do you have any idea if you stratify patients between those with higher BMI and those with lower BMI that look like these metabolic surgery patients, just mildly obese? Is it different, or is it stands also in the lower part of your BMI distribution?
It is very clear that weight loss is extremely important for improvement in glycemic control. So let's be clear about that. But in addition, we believe, and I think that our data show and our analysis show, that there is also a weight loss independent effect of the gastric bypass surgery. But that said, I think that the greater the weight loss, the greater the improvement. And if you a person with a BMI of 30 and a person with a BMI of 50 have a very different type of diabetes. With a patient with a BMI of 50, that's insulin resistant dominating. With a patient with a BMI of 30, it's reduced beta cell function. And I showed you that both insulin sensitivity and beta cell function may improve after the surgery, but clearly insulin sensitivity improves much more than the potential improvement in beta cell function. So I don't think that the results will be as good in the lower BMI category, but that's my opinion.
Francesco, quick question.
Yeah, I agree completely with Professor Patou's consideration. You're totally right that the guidelines should align the difference in metabolic effect between sleeve and gastric bypass. But the choice of operation in the diabetic patients is a complex one. And the issue of bone mineral density is only one of the many. Usually diabetic patients are older and more frail. So the metabolic outcome as measured by numbers like HbA1c and glucose is only one. What's your comment about?
I didn't hear the last...
So that the simple numbers of a metabolic control, like HbA1c and glucose levels, are not the only determinants, but the clinical result is most important.
Yeah, of course. And we have several outcomes, and you have to take all them together and make a decision with the patients. I don't disagree with you. And reduction in bone, or the reduction in bone mass is one of them, of course. So this is not easy, and I don't say that all patients with diabetes should be operated with gastric bypass, but I think the patient should be presented with these results.
Thank you so much. We move to the next talk. It's my pleasure to introduce François Patou, speaking about NASH as a summary of the title, but I also wish to remind to the audience that he's the co-president of the IFSO 2027 in Paris. So we are happy that you got this satisfaction.
So thank you very much. It's a bit early to welcome you in Paris in 4 years. I hope I will be still there, but let's see. Okay, so today I'm going to talk to you about the liver. So first of all, I would like to apologize. I'm not in the first league. We have heard about the first league, randomized trial. I will just show you level 2 evidence, which is cohort exploratory results.
François, please, a bit
closer.
closer.
Thank you. That's a major difference. That was my warning. So my disclosure. And this is the paper I was invited for. So this is the last of a series of papers that, and I'm going to tell you the story behind that. I was published in 2 years from now, the third of a series. So this is first a teamwork. You cannot do this type of studies without a teamwork. We're including surgeons, of course, but also scientists, hepatologists, diabetologists. A lot of people are working behind this Lille-Abos cohort study. So this started nearly in the past century, when I was just beginning this business of bariatric surgery, but the real Abos cohort study started in 2006, 15 years from now. So the idea is to do a comprehensive assessment during follow-up, including preoperative and postoperative, the most complete and comprehensive we can, including lack of attrition. We want to keep the patient in. And that has been an obsession for the last nearly 20 years now. So we are just talking about phenotype, but there are many things. There is also omics that will come, has already been published, but I will tell today about liver histology. So the thing is that everyone who accept to be enrolled, and that's 2 out of 3 patients in our department, at 1 year and 5 years, and then 10 years that will come later, exactly the same dense phenotyping that before the surgery. And we do the 3 types of surgery, including burn in the beginning, which is very interesting in terms of knowledge. So just to show you some results you can have with this type of cohort. First, we were able to see that, of course, we have the same remission rates than everywhere, but there is heterogeneity behind these results. And these data were published last year in Lancet Endocrinology that tells you if you do with this new clustering of diabetes that separates type 2 diabetes in different disease, you have a specific type of patients with SIRD, which is called severe insulin resistance diabetes, which is a 15% of type 2 diabetes. These are the ones who respond the best. Not only, which is expected, not only in terms of remission of diabetes, because 9 patients out of 10 will have remission. And these results have been copycat in Brazil with Ricardo Cohen data, exactly the same. But interestingly, with the kidney. So this was the first time the kidney outcome was looked at, and we see that these patients respond better in terms of kidney function. Another type of result we have recently achieved is this personalized prediction of 5 years weight loss trajectory. So this is absolutely available and free, and we can just look at that. It was published yesterday in the Lancet Digital Health. This is a huge effort that I include many in the room, and I thank them. The idea is that for each patient, with very simple variables, we started with 500 variables pre-op, we down that number to 7 variables that are listed on the left, very simple clinical variables that tell most of the prediction of this very subtle trajectory. And you can see the shape. You've seen the shape several times before in this conference. And exactly here you can see sleeve versus bypass. And what do you see? At 1 year it is the same, at 5 years it is not. And this has been validated worldwide in 10 different cohorts from Singapore to Mexico to Scandinavia to Switzerland, and thanks to our colleagues also in randomized trials, the 2 trials that we've seen, they have accepted to see that individual data into that. So that's now quite a robust tool, and I invite you to look at it. But let's talk about my subject, metabolic associated steatotic liver disease. NAFLD doesn't exist anymore. This is the new name. Metabolic muscle D. Okay, that's important. The disease has not changed too much, only the name. This is a trend disease. First, the pathogenesis is not very well understood. That happens often in medicine. But the diagnosis requires an invasive liver biopsy. That's something which is very strange. For diabetes, you need 1 blood sample. And the disease progression is not very well known, and of course, it's very variable. Plus, it's an unmet medical need. There is not a single drug approved. Then it's an orphan disease. Extremely frequent, but an orphan disease yet. So we don't know exactly how it goes from the so-called NAFLD before, NASH or MASH today, to cirrhosis. And there is a little bit discussion about the prevalence. So that was interesting in our cohort, where surprisingly enough, we have been proposing, and I can tell you in the questions how I did that 20 years ago, because the liver was a question at that time of fear, because of some old operations, that we proposed to patients to have a biopsy during surgery, everyone, but also at 1 year and 5 years. And many of them accepted. In the beginning of the study, 2/3 of them accepted to have the routine biopsy, research biopsy, for their good care at 5 years. So that gives us a very unique series of results that is unique. There is no other thing, and there will be never any other thing like that with liver histology. So first of all, what is the natural history, the prevalence of, so that is a liver you can see sometimes. You know, now that's a biopsy, of course, you know that it's quite easy to do. This is exactly what we have in this cohort. More than 1,500 patients in the starting thing, now 2,000 in fact. And you can see that the prevalence, at least in our hands, where we biopsy everyone, even those with a perfectly normal biopsy liver, before with biology and during surgery, we have seen that 12% of them have a real diagnostic of NASH, which is much less than in many cohorts where I think a selection bias occurs because patients with with a stronger liver disease macroscopically or biologically are more prone to be biopsied. So the next information is the first one we published was a long time ago. It was an observation that was already there. There was a routine liver biopsy in research. Complete resolution of muscle D is possible, exactly like in hepatitis. If you kill the cause, and here it's the obesity and weight, and if you kill the cause, the disease disappears. Exactly like if you kill the virus, the hepatitis will disappear, consequence on the liver will disappear. So you can see a real patient, same biopsy, same patients before 1 year and 5 years. We went back to the pathologist, took the picture. That's an awful liver that becomes a strictly normal liver 5 years later. That's what you do with your patients when you operate on them and you follow them 5 years. Interestingly, of course, fibrosis is important. This is first the MASH, at that time NASH, so the steatohepatitis. It's quite amazing. In this prospective study, 180 patients had repeated biopsy. 80% of them just have no more MASH at 1 year. After 1 year, 8 out of 10 have the same, and same numbers are seen at 5 years. Everything happens in the first years. Steatohepatitis. But more importantly was fibrosis. Because fibrosis is the killer, at least the sign of the killer. Because this is associated, this has been associated with death, with mortality in the long term. And we need to have F2, significant fibrosis. F1 is just not a disease, but F2 starts to be significantly associated with mortality and liver-related event in the future. So this is what we see. At 1 year it starts, but at 5 years, nearly more than half of the patients, have a nearly normal liver. And if you just put these numbers together, you can see that it's delayed with the fibrosis, but at 5 years, you can see that nearly 2/3 of patients, even those with advanced liver disease, and that was recently reanalyzed, have no more advanced liver fibrosis. So this is another way to put the same results in. That means that you have all the patients with repeated biopsy with severe advanced fibrosis to start with. And you can see that it goes down globally. But of course, there is some outliers that goes up, but very few, in fact, exactly like diabetes. But you can see that even patients with F4, they were not operated knowing that they had cirrhosis, because of course, at that time, there was a contraindication in France. But they had F4 at the biopsy. But you can see that these patients are decreasing and they are going out of the cirrhosis zone, out of the F4. And you can see also that at the end of the day, if you separate advanced or significant fibrosis to resolution of significant fibrosis, 1 out of 2 at 1 year, 2 out of 3 at 5 years had remission, resolution of advanced fibrosis, which is the goal of the drug trial, but was never achieved with any of these trials before. Of course, there is another view of that. This is risk. And this study also allowed us to look at risk. Just as a crude number, we have used a textbook. Of course, complications are not so frequent, hopefully, in our cohorts of bariatric surgery, like all of yours. You know that this is quite safe these days. So we use a textbook outcome. Textbook outcome, perfect patients, short stay, no reoperation, no death, of course, but nothing. Perfect. This is textbook outcome. So the complication rate is here, non-textbook outcome. Something went wrong. Not always bad, but something not normal. And if you look at that, and you have an incremental severity of liver disease from healthy disease, healthy liver, to NAFLS, steatosis only, and then NASH without fibrosis or NASH with fibrosis, you have a clear incremental of complication risk. The patients with NASH and fibrosis F2 are at risk. And we're not talking about F4 or F3, the compensated cirrhotic, not even the uncompensated that we don't operate. That's important to check, because that's patients that are very difficult to treat. And interestingly, because of course this is traveling together with diabetes, difficult to know, is it diabetes, which is known as a risk factor for complication? So we did this type of analysis, with a statistician to check the independence of these different factors. And you can see with these, let's say, simple diagrams, but at the end of the day, it's a quite simple figure to understand that NASH without fibrosis alone, independently of diabetes, increased by 2 times the risk of non-textbook outcome. And fibrosis adds on that. But it seems that NASH, which was not known, because fibrosis it's known, cirrhosis, of course, it's known in general surgery, but NASH per se, independently of diabetes, is a risk factor. So these are not trivial patients to treat and to put on the table. You have to be very careful. They are not the same one. So we have to be careful when we look at the big picture of complications. The complications occur in these patients. Okay, so if I'm now summarizing my 14 minutes, it's just a few bullet points. What we learned from this non-level 1 cohort study. First, MASH can disappear, and this is proven by histology, repeated in a research prospective cohort, in 80% of cases. I have MASH, I don't have MASH 1 year later, 8 times out of 10. First one, fibrosis also can regress. And this is a reminder of hepatitis. Exactly the same. If you kill the virus and you wait long enough, there is no fibrosis anymore. And we know that transplantation has nearly disappeared in the virology world. There is very little now transplantation for patients with cirrhosis from hepatitis because they have been treated 5 to 10 years ago now. Third, surgery in MASH can be complicated. Never forget that this is a risk factor which is independent from others. The patients are tough. They're not the most heavy ones. They are maybe seems okay, but they are not. And we are not talking about the cirrhosis, which is another subject, even more difficult. But we are talking about the one you don't know. So if you don't assess it, you will not know. But of course, most of them are severely diabetic. And finally, of course, we are now moving to the surgery for MASH, which is very different than surgery in NASH that I just showed you. I just showed you a result about I have operated patients, we have done biopsy, and at the end of the day, we looked at the one with NASH, but we didn't know. So this is a very different business from I have NASH, whatever my BMI, and my treatment will be surgery. And this is the new question. And we heard in this meeting, and you read maybe this year, a few months ago, that Gertrude Mingron in Roma was the first one, and she should be here in the Champions League, with the first randomized trial, exactly the same results, meaning that in her study, after 1 year, which is only 1 year, with biopsy, in per protocol, so the one who have been actually biopsied, 50% NASH resolution, 70% NASH resolution at 1 year, 50% fibrosis improvement, very similar to our results. And finally, I would just like to make a small, not comment, but suggestion, biopsy. Liver biopsy at the time of surgery. It's an easy thing. There is no risk. We have done that 3,000 of times. We have not seen a single real complication from that. So really, I think it's a safe and sound measure. Whatever happens, just do a biopsy. You can document things. You will follow your patients. You can select those who you want to follow better. I think it's a size. It's an important suggestion. I urge you to consider it. Either in your country it is okay to do that. Okay, with that I am happy to answer any question. And if you want to check the thing, it's easy. You can just log in online.
Thank you.
Thank you very much for your attention.
Paper is open for discussion. Question from the floor. Ralph Peterli. In a rush.
Thank you very much for this great presentation. And don't put yourself down doing prospective cohort studies. RCTs are good for certain things, but I mean, evidence comes from these trials. You made us look at the liver. You had another goal because you were afraid you will do liver damage, but because you did it, you gave us the chance to now have good randomized trials. So don't put yourself down. I really don't do that.
You know how humility is my main characteristic. Don't worry, don't worry. I was playing the role.
Here's another question. Yes?
Atisa Polio from Switzerland. Like you told us, you do every time intraoperative liver biopsies. And what is the consequence? How does the postoperative follow-up change for you when you get the histological results?
Okay, that's a good point. I think I was maybe overstating my suggestion. So I think that today, no, but agree. The thing is that what I would say is as soon as you have any glimpse of anything, biologically or clinically, I would do that. Because I think it's an important thing to follow that later. So I don't say it will change everything because the operation is done, but I think it's interesting to do. So let's say that my suggestion would be, because you can screen patients and rule out significant fibrosis quite easily. To diagnose it is very difficult with a non-invasive test. So I would say, yeah, you're right. Thank you for your comment.
Thank you. I just have another quick question. We also, which will be published in SORT, I think, next month. And we also took...
Speak loudly.
120 intraoperative biopsies and operatively graded it NAFL and NASH. And we calculated the HOMA B and the RR index, and we saw that the NAFL and NASH patients had similar insulin resistance, but the NASH patients had a worse beta cell function. So we postulated that the progression from NAFL to NASH will be a decompensation in beta cell function. Do you have an opinion on this, what the trigger might be from NAFL to NASH to fibrosis?
Okay. Congratulations. I will read that with very much interest. We have a view, but that's intuition, which is exactly the opposite. Meaning that we think that what is going to inflame the liver is hyperinsulinism. And there is several pieces of evidence from the cohort from Sweden and now from Wagner, from Germany, that said that this severe insulin resistant, than Nolan and Prenke are calling severe insulin hypersecreting patients, because they are the same. Hyperinsulinism might be for some researchers the problem, or one of the major problems to start with in diabetes. Hyperinsulinism being the cause of insulin resistance, that's a piece of thought that is really in the literature. And it seems that these patients with MASH, steatotic inflammation, higher kidney disease, and I showed you that these patients have higher kidney disease, are maybe those with hyperinsulinism. So maybe the question is still open, and I would be prudent.
Francois, I have a question for you, which is not a scientific one. Because you address a point we are convinced about us, we are surgeons, but under the experience of the treatment of diabetes, we struggles for sometimes with our colleagues. What is your suggestion to cooperate with hepatologists, convincing them that the treatment is effective? I know that it's not an easy question, but surgeons are convinced.
Okay, but easier than you think. Sorry for my internist colleague. I don't know if he's on the side of diabetologists, and I know Rachel is. Diabetologists are very careful internists. They are dealing with a slow evolving disease. No one is operated. No one is at risk of death with transplantation, things like that. So it's a difficult corporation to work with when you're bringing such an invasive treatment as surgery. You see that. When you go with cardiologists, and they are coming, they are the next one with heart failure, the cardiologist or the hepatologist, these colleagues are dealing with invasive treatment. A transplantation of the heart or liver is something that can really be deadly, much more than 1 per 1,000 as we do. So I can tell you that hepatologists are really up to go there. And I can tell you that because there is no drugs and it seems to be far away. We are not talking about the slight little, fatty liver. We are talking about F3, F4, the patients who are going to die, the patients who are not going to be treated by GLP-1 analogs easily. And these patients, they are now convinced that it's better to do that to prevent transplantation than to wait 10 years and have transplantation. So I would say that go to your hepatologist with the literature, and as soon as they will embark to that, you will be surprised how empathic they are compared to the diabetologist. And I love diabetologists, by the way.
Thank you so much, Francois. Thank you so much. Now, talking about what he has addressed, it's my pleasure to introduce Rachel Bartram, the Body Optimized study. She's such a big expert. She can give us a lot of good advices about this unpublished data.
Thank you and good afternoon, everybody. I love following Francois. It's the second IFSO meeting. He's so energetic. So it's really always nice to follow him. I want to start off by thanking the first author on this study, Jess Mock, who will be here tomorrow, who's a surgeon, and she'll be around tomorrow. Here are my disclosures. Right, and now let's move on to the key thing. We all know that there's variability in the weight loss response to bariatric surgery. This is not the patient, not the surgeon, it's biology. And does it matter? It matters because many of the complications that we're trying to treat are weight loss dependent. So if we move out from surgery 3-4 years, then the health benefits are related to the amount of weight loss. Well, we know that the biological response in people with a suboptimal weight loss is not as good. So if we look at satiety hormones, PYY, GLP-1, then the levels are lower. And there's also higher levels of ghrelin, the hunger hormone, in people with a poor response. At the moment, we only have drugs that can target the GLP-1 part of this response. So our hypothesis was that if we took people with a suboptimal response to bariatric surgery who also had low GLP-1 levels, and we gave them back a GLP-1 agonist, then we would see additional weight loss. So this is kind of personalized medicine. Not everybody with a poor weight loss response has a low GLP-1, but some do. So we weren't giving it to everybody. We were giving it just to the people where we measured their GLP-1 after surgery and the levels were low. So this was a superiority study. So we were trying to prove that liraglutide was superior to placebo. Both groups had a lifestyle intervention, so a 500-calorie deficit diet, physical activity, and it was in people who were at least 1 year after primary sleeve gastrectomy or bariatric or Roux-en-Y gastric bypass. So we had 70 patients who were randomized 1-to-1, and there's a dose escalation period because this is using liraglutide 3 milligrams, so the first generation GLP-1, which is a once daily injection. So you increase the dose over the first 4 weeks, and then it was 20 weeks of maintenance dose. So quite a short study, which is based on the funding that we had. So it was only a 20 weeks of full dose. And we also had the lucky experience of trying to do this during COVID. Never do a study during COVID, but once you're in the middle of it, then you have to try and deal with it. But the problem was that our primary outcome, which was an in-person weight assessment for several of our participants, we couldn't get this because people with obesity were not allowed to come into the hospital, and the whole of the UK went into lockdown. So the key inclusion criteria were being 1 year or more after primary surgery, less than 20% weight loss. Now, we can argue where the definition of suboptimal weight loss is, but we went with less than 20%. They had to be adults, and also they all had a meal test where we measured their GLP-1 levels. So this is active GLP-1 level. And the primary outcome was percentage change in body weight. We also looked at categorical weight loss. We did DEXA scans to look at changes in fat mass, lean mass, bone mass. We looked at changes in appetite scores and gut hormones, glycemic measurements, and also cardiometabolic risk factors. We also looked at quality of life, looked at 6-minute walk test, and other functional markers, and obviously safety. So this is the consort diagram. So we had 154 people whose records we screened, and 84, and these are the people who also then underwent a GLP-1 test. 84 were excluded, 70 were randomized. 35 were randomized to liraglutide, 35 to placebo. We lost 4 to follow-up in both groups. And then we had the issues with the last weight measurements in both arms. We did actually go out. Jess, who was doing the study, went to the patients' homes, covered in a gown with masks on, and we managed to get a body weight. But obviously we couldn't include it because it wasn't using the actual set of scales in the hospital. So we do have the data, but our statistical analysis stats people wouldn't let us include that when we came to do it. So who were these people? So they were predominantly female, which represents the population having bariatric surgery in the UK. Some of them had type 2 diabetes, but less than we see. So about 25% of people who have type 2 diabetes, 25% of people who have bariatric surgery have type 2 diabetes. So there are fewer people with type 2 diabetes, and that's probably because most people with type 2 diabetes end up having a gastric bypass. And if you look at the prevalence of looking at operations, then nearly all of these people with poor weight loss and a poor GLP-1 response had had a sleeve gastrectomy. Now, you'd anticipate that because of the different biological effects of these operations. You get a much higher GLP-1 when you bypass, because then you're directly stimulating the L cells. Whereas with a sleeve gastrectomy, you get increase in GLP-1 as a consequence of increased gastric emptying. If we look post-surgery, so on average, they were 4 or 5 years after surgery, and the average weight loss since the day of surgery was only 7%. They still had a very high BMI, over 40, and if we look at the categorical BMI categories, then over 50% still had a BMI over 40 despite having had metabolic bariatric surgery. The majority were white, but we had a decent number of people of black ethnicity and also a few other ethnic variations. So again, baseline demographics, going back, just to show you that, again, the average weight was 123 kilos. And then I've put down the bottom the active GLP-1. So the way that we do this is similar to doing a glucose tolerance test. The person fasts overnight. They come in, we take a 0 with a venipuncture. They then drink a standardized drink, and then we take a sample at 30 minutes. So it's relatively easy to do when you're doing it in the outpatient setting. This shows you the change in body weight, percentage body weight over time. And again, this was only 20 weeks of the maximum dose and using the first generation GLP-1 receptor agonists. So the estimated treatment difference is 8.2% in terms of body weight, and this was highly significant. Interestingly, the placebo group did not lose any weight. And that's different than if you take a population and just put them on a GLP-1. So if you look at all of the studies comparing GLP-1 receptor agonists and placebo in a group that haven't had bariatric surgery, then the placebo group lose weight. Now that's because that population of patients have not been through everything that bariatric surgery patients have been through. They've already had lifestyle advice to death. They've already tried everything. They've already optimized their diet. So by giving them an additional lifestyle intervention, it doesn't really change anything. So that's the difference here, whereas the liraglutide treated group did lose weight because we were giving them a treatment of GLP-1. This is the waterfall plot, again showing the variation in response. So we had people losing over 20% of their body weight in this 20-week period. And as you can see, the placebo group, there's a variation in response over the 20-week period. And if you look at actual kilograms in body weight, then again, on average, treatment difference of 9 kilos over a 20-week period. What about categorical weight loss? Then 70% achieve 5% body weight, 28% achieve 10%, and 12% achieve 20% in the 20-week period. Lots of information on this slide, looking at the other various outcomes using multilinear regression analysis. So anything that goes over the 0 isn't really significant. So we see obviously reductions in fat mass, we see improvements in glucose, HbA1c, cholesterol. We also see an improvement in physical functioning, and various other measures of the I-QOL-Light score were improved just over a 20-week period. What about adverse events? Because again, there's a concern that if you're giving GLP-1s after surgery, you might get more adverse events. We saw nothing different than we would in a population that hadn't had bariatric surgery. And actually, the nausea seemed to be less. So whether that's because patients who've had bariatric surgery have already had high gut hormone levels and they've got tolerance to them, and only one in each group experienced vomiting. Again, nothing new in terms of the side effect profile after GLP-1 that we haven't, so very similar side effect profile to people who haven't had bariatric surgery. What we didn't do, though, was give this to people who had a high GLP-1. So we don't know whether the low GLP-1 was important here. And if you look at the effect that we saw in this study compared to the trials in people who haven't had bariatric surgery, then the weight loss is greater. So whether it's because we used a personalized tailored response, we don't know. Ideally, we should have done a 3-arm experiment where we tailored it to people with low GLP-1, gave it to anybody, and then also had placebo. And there's an ongoing clinical trial using semaglutide where this has been given to everybody, but we've measured the GLP-1 to know what the response is, but we're giving it to everybody rather than doing it based on GLP-1 levels. So to conclude the barioptimized style, it showed that liraglutide, once daily, leads to clinically meaningful weight loss in a relatively short period of time, and it was associated with improvements in cardiometabolic risk factors. And from a safety perspective, there was no concern about any new safety signal from using it in this patient group. So I think this shows that we should be looking at combination therapy and going forward, sort of maybe treatments before surgery to lose weight, surgery, and then in those who need it after surgery, then actually pharmacotherapy is an option. But clearly, it then needs to be lifelong pharmacotherapy, because when you stop it, then the people put the weight back on. So just to mention all the team who are involved in this study: Novo Nordisk, who provided the liraglutide and placebo, and also the people who funded it. And thank you very much for your attention.
Thank you, Rachel. We already have a question from the floor, please. Please.
Thank you and congratulations. My name is Göran Elmseth. I'm from Norway, Dr. Hofso's group. Well, actually, he's in my group. I think the most important thing you mentioned in the last part of your presentation is that why measuring the postprandial GLP-1 response? Because the treatment is not focusing on the postprandial GLP response, but you're giving a drug which is stable and high during the... So I believe that you may have similar results in all patients in the next semaglutide study.
Yeah, I think we probably will. So you probably need to wait a year to find out. And also that's obviously easier because it's hard to measure GLP-1. It's a difficult hormone, it's a difficult assay, so it wouldn't be taken. It was more sort of a proof of concept, making it more personalized, and also with more efficacious medications, then you don't need to tweak it quite so much.
Torsten.
Thank you, Rachel. Always doing great studies. The one you would like to have done yourself. So taking it again from where Göran was asking, is it two different treatments happening to address GLP-1 receptor? And I just want to have your comments about those responding or not responding to GLP-1 receptors before surgery. Should that guide us in any way?
So I guess the question is, we really need to identify the people who are going to have a poor weight loss response to surgery. And we've done lots of studies where we've tried to measure GLP-1 prior to surgery, and you can't predict it because you don't know how the L cells are going to respond until you've done the surgery. But maybe we can. Maybe we can try and get nutrients further down the gut to see what's going to happen to the GLP-1 response, because there's a huge variation. And how somebody responds to a GLP-1 agonist doesn't predict their response to surgery at all, because the key thing is how much of your own endogenous GLP-1 you release. And also the other thing is that after surgery, you've still got all the other hormones that have been changed. So even though we're giving GLP-1, we're giving GLP-1 in addition to having changed PYY, ghrelin, exintemodulin, the enteric nervous system, the microbiome. So it's actually almost combination therapy, but giving a higher level of GLP-1.
Michel Souter.
Congratulations, Rachel. Sorry, my voice is bad. Do you have longer-term results? One of the limitations, as you mentioned, is it's a very short-term study. Yeah. Did you follow these patients later on?
No, because they were in lockdown for another 6 months. So, but hopefully as anti-obesity medications get approval and reimbursement with registries, then we'll be able to see this. And I think this is where the surgical registries will also be really important to capture these data of the people who've had medication prior to surgery and then the people who need it after surgery, because I think at the moment you're the only community that have really good registries, and we should really be looking at this going forward. Francois.
Thank you very much, Rachel. Again, a wonderful study. I would like not to tackle you about this study, but I would like to take the opportunity to have one of the most experienced GLP-1 prescriber worldwide, who has done all the studies. I've seen some differences and some poor responder. What is your expectation in terms of let's propose surgery to the poor responders to GLP-1 agonists? Do you have any expectation? Are they the same poor responders when you respond well or bad? What do you think?
I think they're so different biologically that you can't use one to predict the other. The advantage of giving a medication is if it doesn't work, you can try something else. Once you've done the surgery, you've done the surgery. So I think sort of trying to work out, if we can, who will do well with surgery is really critical, but we can't do that by giving other drugs because it's how the endogenous system responds.
But my question is, you have experience with patients who did not respond to drugs. Some of them have been operated, I'm pretty sure, in UK. So what is the result? Because this is what we are expecting in the coming years to change our world. These patients will exist for us.
So the problem is that within the UK, we have very limited access to anti-obesity medication. So if you look at the first generation drugs, then the response wasn't great. Now, as you're going to the second generation drugs, where you're getting 95% of people responding with 5% weight loss, it's partly that the drugs have got better and we're using combination approaches. So
we don't know. Okay.
Yeah, we don't know.
One, a quick question because you're running out of time.
Yeah, well, okay. Again, congratulations, fantastic work. But my worry, and probably most of us as surgeons, is that these drugs create a dependence, and you have to maintain them for good, for life. We don't know how, what are their effects at the long term, and will the patient have to be engaged to these drugs all the life, the whole life?
Obesity is a chronic disease. If somebody has asthma, COPD, hypertension, they take drugs for the rest of their life.
We don't know the effects at the long term.
But many other medical areas, we don't know the effects, but we still treat it. So the issue is that we need to understand how to reset the set points that Lee Kaplan was talking about. The moment we're treating the symptoms of obesity, and that's what bariatric surgery is doing. If you reverse the bypass, somebody puts the weight back on, because bariatric surgery is providing long-term treatment. And unless we really understand that obesity is a chronic disease and we understand how to reset the set point in the brain, then that's where we need to go to. But yes, people who have treatment need the treatment long-term. That's how come bariatric surgery is more cost-effective.
Thank you, Rachel.
Thank you.
Thank you very much for this presentation and for all the information that you provide us about all these new drugs. Please.
So let me introduce you Professor John Melissas, who was the president of a World Congress of IFSO in Krisia some years ago, and he's in charge of the European Accreditation Council for the Center of Excellence that he participated to create it in the past, and he will tell us about his work. Thank you, John.
Mr. President and upcoming President, thank you for the opportunity to be here and present data from IFSO Center of Excellence program. Those are my disclosures. Now, everybody knows what is a COE. A COE, a Center of Excellence, is an institution and surgeon or surgeons able to offer a safe and effective treatment to the patients with obesity and metabolic diseases. Now, who decides about that this particular surgeon and hospital can do this excellent job? Obviously, an independent organization is needed to do this evaluation. This is there is in Capri in 2008 here in Italy, during the General Assembly of the surgeons from Europe, Middle East, and Africa. It was unanimously accepted the idea of having a COE program in this part of the world. Therefore, the European Accreditation Council for Bariatric Surgery was formed. It's the organization who examines institutional facilities, surgeons' qualifications and experience, the results of treatment in order to suggest to IFSO who is able to receive the COE designation. The body who makes the final decision is the Scientific Board of the European Accreditation Council for Bariatric Surgery, with first president being our honorary and founding president, Nicolas Copinaro. Following his tragic loss, president now of the Scientific Board is Professor Rudolf Weinel from Germany. Now, the European Accreditation Council has a website where you can find all the relevant information. You can apply for participation online, and you can enter prospectively your operated patients. EACBS uses an international bariatric registry, which was formed in Salfalden in 2010 by a group of senior surgeons from the European chapter that they met and decided about the details of the program. So far, 103 hospitals and 164 surgeons are accepted to participate. 61 institutions and 86 surgeons are fully qualified. The rest are still under evaluation, or the designation was denied to them for several reasons. In this slide, you can see the ratio between private, academic, and state hospitals. The majority, more than 50%, are private hospitals. There are participating surgeons from 30 countries, from all the European countries, Middle East, Africa, and also from Asia. India has some center of excellence. Now, it is interesting to see the type and the number of operations that have been entered in the International Bariatric Registry from the initiation of the program in the different phases. For instance, the first 2 years, and while we had 12,185 patients enter in the database, the most often used procedure was sleeve Roux-en-Y gastric bypass followed by sleeve gastrectomy. And by that time, it was also a good number of procedures, laparoscopic adjustable gastric banding. The one anastomosis gastric bypass by that time was not visible. It was entered together with other occasionally used operations under other procedures. It's also of interest to see the number of sleeves and Roux-en-Y gastric bypasses that they have been entered in the database every year. Up to 2013, the most common used operation was Roux-en-Y gastric bypass. From 2014, sleeve gastrectomy prevailed and is since today the surgeon's preference. Thus, in 2019, and while we had more than 79,000 operations as primary, two-stage, and redo procedures entered in the database, most common operation is now sleeve gastrectomy, followed by Roux-en-Y gastric bypass, and the mini gastric bypass is visible here with 10.24% of the cases, and the adjustable gastric banding as low as 4%. Now, up to date, we have 105,000 plus operations, primary procedures. We have 3,677 operations planned for two stages and receives the first operation, and another 836 patients that they planned for two stages and they had also the second part of the scheduled procedure, and 8,124 redo operations. Therefore, we have more than 118,000 patients available for analysis. Those are all the procedures as appear today in the database. Sleeve gastrectomy first with 55%, Roux-en-Y 26%, one anastomosis gastric bypass 11.4%, other bariatric procedures, and here I have to say that are acceptable and quite often used today operations such as SADI-S, such as SASI and bipartition, and then others in smaller number. The redo operations, the Roux-en-Y gastric bypass is the most often used as a redo procedure, 40% of the cases. Other bariatric procedures, and as I said, here is SADI-S, is SASI, is transit bipartition, and other powerful in terms of weight loss procedure. Sleeve gastrectomy is then, and then one anastomosis gastric bypass is fourth. What about safety? Let's see what about the complications. Those are the complications of the primary procedures. 620 serious and potentially life-threatening complications have been recorded. This is about one serious complication every 200 procedures. We had also one death during intraoperative death during sleeve, another one intraoperative death during Roux-en-Y gastric bypass. Bleeding, gastrointestinal perforation, and liver injury, the most common serious complications. Postoperative complications, about double. Therefore, one complication every 100 procedures. And again, bleeding, leak, intra-abdominal abscess, and vomiting, the most common complications postoperatively. Early readmissions following discharge, the first 30 days, are those with more common leak, abscess, bleeding, and vomiting. And it seems that Roux-en-Y gastric bypass carries the more risk to develop complications postoperatively, followed by one anastomosis gastric bypass. What about late readmissions following discharge? 837 patients with gastroesophageal reflux disease, gastric stomal ulcers, vomiting, intestinal obstruction, and others in smaller numbers are the reasons for late readmissions. And again here, one anastomosis gastric bypass seems that carries the more risk for late readmission, followed by Roux-en-Y gastric bypass. But what mortality? Mortality is extremely low, 33 patients for all categories. In other words, it's one death every 3,500 procedures. Obviously, the primary, they have less risk for developing complications, for developing mortality. We have 0.02 or one death every 5,000 operations. and then the two stages and the redo procedures carry more risk for mortality. Those data can compare very favorably with other published series, all of them indicating that in COEs, surgery can be done with safety and effectiveness. And also, this data from this study support other published series indicating that there is much lower mortality and morbidity in certified versus non-certified centers. Excess weight loss for all categories of primary, for all primary operations, quite good, 71, 76, 72%, the first, second, and third year respectively. And those are the excess weight loss that has been recorded for the three most used operations, the sleeve gastrectomy, Roux-en-Y gastric bypass, one anastomosis gastric bypass. Seems that the latest is the more powerful weapon in terms of weight loss. Diabetes type 2 remission, very good results from the COE as reported for the remission of diabetes and improvement of diabetes at 12, 24, 36 months. And again here, sleeve, Roux-en-Y, and one anastomosis gastric bypass, diabetes remission at 12, 24, 36 months respectively. And again here, the one anastomosis gastric bypass seems to be that it's more effective operation for treating diabetes. What about follow-up? Do we follow our patients for life, as is the rule? As we used to say, it's not the rule. Or do we follow at least a good portion of our patients? The answer is not. It's clearly not. Maybe the first year, this is from all COEs, 67% of the patients followed up for a year. The follow-up is declining continuously and is as low as 18% at the end of the fifth year. Now, are there variations among certified COEs? Are there differences? And does the number, the volume of operated patients matters in the results? Now, to answer this question, I study the top 5 surgeons in terms of patients entered in the database. Catalin Copaescu is the champion, is the best, with 7,700 operated patients. Giuseppe Marinari from here, from Italy. Mohamed Krais from Jordan. Sultan Al Temiat from Saudi Arabia. And Pierre Feskens from the Netherlands are those guys with more than 1,000, let's say, operations entering the database. And those, I don't mention name here, are the surgeons with the lower, let's say, volume, not very low, between 500 and 600 patients, but anyway, low volume surgeons. So indeed, there are some variations in favor of the high volume patients. They have less intraoperative and less postoperative complications, while other parameters, including mortality, are not statistically different. And also in the follow-up, again, better follow-up in favor of the high volume, which is strange. Usually you expect the low volume to have higher follow-up. And also the diabetes remission, much better results of the high volume centers and surgeons. Now, in conclusion, bariatric and metabolic surgery is performed at IFSO COEs with the highest degree of safety and effectiveness. Sleeve gastrectomy is the procedure with the lowest incidence of complications. Roux-en-Y and anastomosis, gastric bypass, are both safe and effective for treating obesity and diabetes type 2. One anastomosis, gastric bypass, MGB, is slightly better in terms of weight loss and diabetic mellitus remission. And lifetime follow-up of morbidly obese patients is not as realistic expectation. Thank you.
Thank you, John. You really deserve a big applause for the big job you did for all the Europeans bariatric surgery. It's really important for us. Last but not least, thank you so much, John. We go to the center.
Finished?
Questions? Go ahead.
No questions?
Come.
What?
John, come on.
Thank you. Yes. We thank all the, well, no problem. We thank all the speakers for, but no problem. No. I will just want to introduce you the new president of the European chapter, Nicola Di Lorenzo.
No, I have nothing to say. Thank you, everyone. Thank you very much.
Jeg tror vi skal ut og spise.